Hi, and welcome to the show. Subscribe at kevinmd.com/podcast and get CME for this episode by clicking on the CME link in the show notes. Today, we welcome back Banu Symington. She is a hematology oncology physician, and today's Kevin MD article is titled Safeguarding Patient Wellbeing by Opposing Offsite Infusions. Banu, welcome back to the show.
Thank you so much, Kevin.
Now, for those who didn't listen to your first episode, just briefly share your story and journey.
I'm a Philadelphia girl, University of Pennsylvania educated. I never thought I'd end up in a rural setting, but I've been practicing for more than 20 years in highly rural settings and have become a rural patient advocate.
All right. And for those rural oncology patients, hematology oncology patients that you see, just tell us some of the challenges that they face seeking oncology care.
So for rural patients, many of them are uninsured, and I'd say more than in cities. They have to often travel hours just for a routine visit, a routine appointment. And the necessity to travel makes many of them choose non-standard therapies. They may choose a mastectomy instead of lumpectomy with radiation. They may choose to forego various adjuvant therapies. And telemedicine is challenging for them. Not only are they not necessarily medically sophisticated, they may not own an iPhone or an Android or a PC. We regularly have problems with the internet. Our hospital phone lines went down a week ago. So, can you imagine the chaos that would cause? So, even televisits are challenging for these rural patients.
All right. And one of the issues that you talked about was offsite infusions. Your Kevin MD article is titled Safeguarding Patient Wellbeing by Opposing Offsite Infusions. Now, give us some background and context to your article before talking about it.
I'm very active in my organization, the American Society for Clinical Oncology. I was at a state affiliate meeting in May, and they mentioned that three things were coming down the pike: white bagging, brown bagging, and the potential for offsite infusions. They discussed these as things that were going to be remote possibilities. Within a week of coming back to the clinic, two different insurance companies sent me letters indicating they would not pay for chemotherapy delivered in the cancer center. They
Wow.
wanted me to write orders for the patients to get their chemotherapy at an offsite, independent infusion center. I started trying to appeal this process, and that's how that the essay was generated. That was my letter of appeal to the insurance companies. It turns out insurance companies are rolling this out in rural settings first because there are fewer rural practitioners and patients. There's less of a force to argue with them. And I suspect once they've done this for a while, they will say, hey, it's been working great in the rural settings, so we're going to roll it out in urban settings.
Now, tell me what the current standard of care is when it comes to chemotherapy infusions. What's it like now before this new intervention?
So the chemotherapy is usually given in a center that is staffed by oncology certified nurses who are trained to deal with infusion reactions and by physicians like myself who are trained to treat infusion reactions. In many facilities like this one, the cancer center is within the hospital. So if there is an infusion reaction, a code that I can't handle, the code team is in the hospital. We just call a code blue, they come running down. The ER is down the hall. The ER physicians come down and take care of things. In this cancer center, between patients, I run back to the infusion center. I talk to patients. I address the questions that the chemo infusion nurses might have. None of these are options when a patient goes to an independent infusion center. And often the independent infusion center is staffed only by nurses. There is no provider. I hate to use the term provider. There's no physician, there's no nurse practitioner that's oncology trained to help mitigate reactions that may occur at the offsite infusion center.
And who normally would administer an offsite infusion center? Would it be an offshoot of a hospital? Would they be independently owned and operated? Like who runs these offsite centers?
In big cities, they're often owned and run by big corporations like CVS or Walgreens. In our community, it's owned and operated by an independent pharmacist. It's a private for-profit center, but it's not a hospital affiliated infusion center.
Okay, so tell us about some of the risks, and you touched upon that earlier, some of the risks if a proposal like this were to go through.
So the risks are it that a patient can have an infusion reaction at any infusion. There is nothing written in stone that says they only have an infusion reaction with the first or second infusion. There's a risk to the provider because they are still expecting me and providers like me to write the orders for the care to be delivered offsite. I would say the bigger issue isn't so much risk as patient experience. So, a patient with cancer is anxious. A patient with cancer often doesn't feel well. The expectation by the insurance company is that the patient will come here and see me. I will use myself as the example. I will evaluate them, write their orders, and send them with the orders to this offsite center. So that is a very interrupted, inconvenient plan for someone who's not feeling very well. So, putting safety concerns aside, is that the way you'd want your mother to have her chemotherapy? The patients develop a relationship here with the nurses, and they can certainly develop a relationship with offsite infusion nurses, but the accessibility of the physician and the ER and Code Blue team is certainly a psychologically reassuring for patients. So what bothers me about this, as well as the brown bagging and white bagging, if you want to touch on those, is that they don't even try to pretend that patient safety, patient experience, patient convenience, or quality are factors. It is simply for their bottom line savings or profit that they are making these changes. So medicine is drastically changing and not to the detriment of the patient. I'll
Is
just
there an
leave it at that.
Is there an argument to be made that sometimes these infusion centers may be closer distance-wise to patients, especially rural settings where you mentioned earlier that they would have to travel sometimes hours to go to a cancer center?
The only infusion center in this catchment area is just a mile away from here.
Okay.
So I doubt it. I doubt it. Maybe in urban areas, there could be an infusion center that is closer than the cancer center, but not in a rural setting like this.
So where are we in terms of executing this proposal? Has this been implemented yet?
Well, I sent my letter of appeal in that was published in Kevin MD, and it was denied. So the insurance company said, regardless of the arguments I made about patient safety, convenience, they were going to move ahead with only agreeing to pay for it if it was given outside the facility. That patient that precipitated the first letter has withdrawn from care. So she has elected not to go elsewhere to get her care and not to pay for it out of pocket to get it here. The insurance company also rebuffed efforts by the hospital finance manager to negotiate a better price. The finance manager said our physician is very uncomfortable writing orders for an offsite infusion. Can we match the price of the infusion center to guarantee that the infusions can be done where the physician can keep an eye on things? They rebuffed that argument.
Now, is this happening only in your local and catchment area? Is this happening in other rural areas across the country? Just give us a national scope of the issue.
So at this since the state affiliate meeting, I've been in touch with members of that group. And there is one other rural physician who is encountering this. None of my urban colleagues have actually had to deal with it yet.
And tell us the sentiment of your oncology colleagues when it comes to this issue.
Well, my colleagues and the American Society for Clinical Oncology think this is an inferior experience for patients. It is risky for the patient. it is inconvenient, and it does risk it's a liability risk for physicians who agree to do this. The American Society for Clinical Oncology has made some guidelines that suggest that no physician should be forced to deliver care in what they believe is a substandard way. But of course, these are society guidelines that the insurance company doesn't have to adhere to.
Now, what if you simply refuse to write an order for an offsite infusion? It seems like they could only do it with a physician's order, and there are very few rural oncologists. What if you just simply said no?
And that's what I had told my finance manager I plan to do. The insurance companies may tell the patient that I am refusing to take care of them. That wouldn't be accurate, but the nuances are hard for a layperson to understand. And the by coercing financial matters, by saying we will pay if you go here but not if you go there, they make the patient kind of an ally in this argument, and the patient is kind of an unwitting ally. They just know they can't afford a $10,000 treatment every 3 weeks. So that, and I may be able to talk to some of them and explain my concerns, but others may just go with their pocketbook. So the concern is that the insurance companies will portray the actions of an individual physician as either abandonment of the patient, or, I mean, it's not fine. I have no financial motivation. I'm not reimbursed by according to volume. I'm not reimbursed by the number of patients I treat. So they can't argue that I'm making a financial argument. And on the other side, if you, a practical matter that I need to mention, I think I mentioned it in the letter, was that we lose money on Medicare patients and Medicaid patients. There's a small profit made on privately insured patients, but that just makes it possible for a cancer center to operate without losing money. If you take away all the patients who provide a small profit, cancer center is going to be operating at a net loss, and there are not many rural hospitals who are already financially struggling who will be able to maintain a cancer center that's operating at a loss. So they're going to force the shutdown of cancer centers in these rural areas, which will just mean these patients will have to drive further for care, and more of them will forego care.
Now, you mentioned other things coming down to pike, brown bagging and white bagging. Briefly touch upon those.
So these are all part of the same plan to help save insurance companies money or maximize their profits. White bagging is where they send the chemotherapy drugs to our pharmacy for us to infuse it. So the pharmacy will not be able to charge that small profit for the drugs. That's one thing. The worst thing, a worse thing is brown bagging, where they deliver the medication to the patient and the patient brings it in. And the concern there is many of these medications have to be handled a certain way, kept at a certain temperature. And if it is not in your hands all the time, you can't guarantee that it's been treated the way it should be treated. And you may end up delivering an ineffective therapy. While we were trying to negotiate, remember the insurance company rebuffed our efforts. We said the physician wants to supervise this and make sure it's delivered in a safe environment. We will, at the very least, we would do white bagging. Send us the drugs. We're willing to forego any profit on the drugs. Let us give the drug in a safe manner. And they just didn't want to negotiate about anything.
Now, tell us what your professional organization is doing to fight these proposals. What's ASCO doing?
We are, they have us meeting with Congress annually and bringing up these topics as things that Congress should be against. But the insurance lobby is so powerful, so rich. Even, I won't name names, but even senators that I respect highly are getting huge donations from big pharma, and it's hard to turn them away. And from insurance companies, I think of them as kind of hand in hand, because they are the representatives of for-profit medicine. And my overarching theme as I age and as I deal with these issues is that for-profit medicine has to go. I mean, it is culpable for many of the things that are eroding healthcare right now.
Now, are these initiatives spearheaded by private insurers? What's Medicare doing?
Medicare is not doing this. Can you believe it? I mean, when Medicare looks like the best and safest alternative, it's something to be concerned about. So want their Medicare wants their patients to be seen here and treated here. Medicaid as well. These are private for-profit insurance companies that want this. And what's concerning to me is that Medicare Advantage is getting a bigger foothold in many communities. And Medicare Advantage is really an HMO product where it's a private insurance that's administering the healthcare, and they are initiating many of the same things in for Medicare patients that they are initiating for non-Medicare patients.
So we could have a scenario where a patient who has Medicare Advantage cannot have their infusion in a hospital cancer center where a traditional Medicare patient can. Is that a plausible scenario going forward?
It is a plausible scenario. And the irony is when you sign the contract to be a Medicare provider, you agree to give Medicare patients quality care that is of the same quality as everyone else. But now we are going to be inadvertently giving Medicare patients better quality care, and maybe Medicare will decide to lower their standards, and everyone will be treated off-site. I don't know, but it is certainly not an experience I would want any of my relatives to have.
We're talking to Banu Symington. She's a hematology oncology physician. Her Kevin MD article is titled Safeguarding Patient Wellbeing by Opposing Offsite Infusions. Banu, tell us some of your take home messages that you want to leave with the Kevin MD audience.
Take home messages. I think we need universal health care. I think all of these initiatives are based on the desire for profit. And I think universal healthcare removes the profit motive from medicine and will eliminate these issues as it will eliminate the prior auth struggles that we're all having. Had I known 30 years ago when I went into medicine that medicine was going to be so degraded, I would not have chosen to be a physician. And my I've sort of switched from advocating only for rural patients to advocating for all patients, especially older patients, patients who don't have a spouse or partner who can advocate for them, who can sit at their bedside. I mean, medical care is deteriorating. Many of the essays in your publication point to various aspects of this. So we need to somehow unite to roll roll not the clock back, but go back to a situation where the physician can choose the treatment based on what they believe is right for the patient, not waste hours on prior authorizations, not struggle with insurance companies about brown bagging and offsite infusions, and their motives in a universal healthcare system. It won't be a profit motive. No one will be suspicious that the physician is doing something to enrich themselves. We need to go back to an earlier era of medicine where the patient didn't have any reason to doubt that the physician was advocating for them.
Banu, thank you so much for sharing your insight, perspective, and time. Thanks again for coming on the show.
Thank you, Kevin.